Hello everyone, now let us discuss about CPT coding guidelines for surgery, integumentary system part 6. In the current session, we will be focusing on repair and adjacent tissue transfer or rearrangement. Now first coming to repair. Repair can be of three types: simple, intermediate and complex. Now coming to the guidelines of repair or closure. Use the codes in this session to designate wound closure utilizing sutures, staples or tissue adhesives. For example, 2-cyanoacrylate, either singly or in combination with each other or in combination with adhesive strips. The codes of repair or closure must be used to designate the wound closure utilizing sutures, staples and tissue adhesives, either singly or in combination with each other. Chemical cauterization, electrocauterization or wound closure using adhesive strips as the sole repair material are included in the appropriate E&M code. If only adhesive strips are used for the repair, they are included in the E&M. You need not code closure codes. But whenever closure codes are utilizing sutures, staples and tissue adhesives in combination with adhesive strips, then you can use the appropriate closure codes. Coming to the various definitions, the repair of wounds may be classified as simple, intermediate and complex. Now coming to simple repair. It is used when the wound is superficial, that is involving primary epidermis or dermis or subcutaneous tissue without significant involvement of deeper structures, and requires simple one-layer closure. Simple repair requires simple one-layer closure. One-layer closure is also a synonym of simple repair. In some scenarios, the physician may document one-layer closure. In that case, you need to code simple repair. Hemostasis and local or topical anesthesia when performed are not reported separately. The topical or local anesthesia should not be reported separately. Now coming to intermediate repair, it includes the repair of wound that in addition to the above require layered closure of one or more deeper layers. Here, not a single layer. Intermediate requires layered closure of one or more of the deeper layers of the subcutaneous tissue and superficial fascia in addition to the skin closure. It includes limited undermining. Intermediate repair includes limited undermining. What is limited undermining? Limited undermining is defined as the distance less than the maximum width of the defect, measured perpendicular to the closure line along at least one entire edge of the defect. Undermining is used or is a technique of closure. Intermediate repair utilizes limited undermining. That is, the distance is less than the maximum width of the defect. And single layer closure of heavily contaminated wounds that have required extensive cleaning or removal of particular matter also constitute intermediate repair. This is an important point. Though the closure is single layer, but the wound is heavily contaminated and required extensive cleaning or removal of particulate matter. Even whenever extensive cleaning and removal of particulate matter and heavily contaminated wounds. In all these three cases, even though the layer is single layer closure, then you need to code intermediate repair. Now coming to complex repair. It includes the repair of wounds that in addition to the requirements for intermediate repair require at least one of the following. In order to code complex repair, one of the following must be there. In addition to requirements of intermediate repair. They are exposure of bone, cartilage, tendon or named neurovascular structure, debridement of wound edges. For example, traumatic lacerations or avulsions. In any of these cases, you can code complex repair. Complex repair utilizes extensive undermining. What is extensive undermining? It is defined as the distance greater than or equal to maximum width of the defect, measured perpendicular to the closure line along at least one entire edge of the defect. In the next slide, I will show the diagrammatic representation of extensive undermining, then you will understand in a better way. As of now, intermediate repair utilizes limited undermining, whereas complex repair utilizes extensive undermining. Involvement of free margins of hemical rim, vermilion border or nostril rim, placement of retention sutures. Necessary preparations include creation of a limited defect for repairs or debridement of complicated lacerations or avulsions. Necessary preparations for complex repair include creation of a limited defect for repairs or debridement of complicated lacerations or avulsions. Complex repair does not include excision of benign or malignant lesions. This point we have discussed when we were talking about excision of benign and malignant lesions. Whenever excision of benign and malignant lesions requires intermediate or complex repair, then you should code both the codes of intermediate repair and complex repair along with the excision of either benign or malignant lesions. And similarly for excisional preparation of wound bed or debridement of open fracture or open dislocation. In all these cases, complex repair is not included. What are they? Excision of benign and malignant lesions, excisional preparation of wound bed, which come under the code range 150022 to 15005, or debridement of an open fracture or open dislocation. In all these cases, you need to code complex repair separately. It is not included. Now coming to the limited undermining and extensive undermining. As we have discussed earlier, the intermediate repair utilizes limited undermining. Limited undermining is defined as the distance less than the maximum width of the defect. Measures perpendicular to the closure line along at least one entire edge of the defect. For example, the defect length is 2 cm. This is the defect. The orange area is the defect area. The length of the defect is 2 centimeters. And this is the line of closure. That means you need to close the entire defect, and this is the line of closure. So what is limited undermining? Here the length of the defect is 2 cm. In case of limited undermining, the distance less than maximum width of the defect. That is the distance less than maximum width of the defect that measures perpendicular to the closure line. If the distance is less than 2 centimeters. Here the defect length is 2 centimeters. In order to go for limited undermining, the distance should be less than 2 centimeters. The distance that the maximum width of the defects measures perpendicular to the closure line along at least one entire edge of the defect. This is the entire edge of the defect. So this must be less than 2 centimeter in order to assume that it is limited undermining. And for extensive undermining is defined as the distance greater than or equal to maximum width of the defect measured perpendicular to the closure line along at least one entire edge of the defect. If the distance is greater than or equal to maximum width of the defect, that is, it is equal to 2 centimeters or greater than 2 centimeters, then it utilizes extensive undermining. Perpendicular to the line of the closure, this entire area is sutured. If the distance is greater than or equal to the maximum width of the defect measured perpendicular to the closure line, then it is extensive undermining. And if the distance is less than the maximum width of the defect measured perpendicular to the closure line, then it is limited undermining. Now coming to the instructions for listing services at time of wound repair. So what must be documented at the time of wound repair? In simple term, what are the services that must be documented at the time of wound repair? The first is repair wound should be measured and recorded in centimeters, whether curved, angular or stellar. And when multiple wounds are repaired, add together the length of those in the same classification and from all anatomical sites that are grouped together in the same code descriptor. If you see the codes, certain anatomical locations are grouped under one code. So whenever all the anatomical, for example, when all the anatomical locations that are grouped under one code, they can be added together. The lengths of those wounds can be added together. For example, add together the lengths of intermediate repairs to the trunks and extremities, because trunks and extremities, they come under one code only. But do not add the lengths of repair from different grouping of anatomical sites. For example, face and extremities. Face comes under different code and extremities comes under different code. In that case, if the patient has two wounds of face and extremities, you should not add the lengths of the repair of these two. Also, do not add together lengths of different classifications, that is intermediate or complex repairs. When more than one classification of wounds is repaired, that is when intermediate and complex wounds are repaired, list the more complicated as the primary procedure and less complicated as the secondary procedure using 59 modifier. That is, if a complex repair and an intermediate repair is done, then you need to first code complex repair followed by intermediate repair along with 59 modifier. Now coming to decontamination and or debridement. Debridement is considered usually debridement is not considered as a separate procedure in the repair closure. But debridement is considered as a separate procedure only when gross contamination, that is gross contamination of the wound requires prolonged cleansing, when appreciable amounts of devitalized or contaminated tissue is repaired, or when debridement is carried out separately without immediate primary closure. In all these three cases, debridement is considered as a separate procedure. What are they? The first point is when the gross contamination requires prolonged cleansing. And second is when appreciable amounts of devitalized or contaminated tissue is removed. And the third is when the debridement is carried out separately without immediate primary closure. In all these cases, debridement is considered as a separate procedure when it is done with closure. Involvement of nerves, blood vessels and tendons. Report under appropriate system, that is nervous system or cardiovascular or musculoskeletal, for repair of these structures. The repair of these associated wounds are included in the primary procedure unless it qualifies a complex repair, in which case 59 modifier applies. Usually, when nerves, blood vessels and tendons are involved, these have separate codes in their appropriate systems, that is nervous system or cardiovascular system or musculoskeletal system. Usually we need to report those codes whenever repair is done. But in certain cases, along with these codes from those appropriate systems, whenever a complex repair qualifies to be reported separately, then you can use complex repair along with 59 modifier. The next point is simple ligation of vessels in an open wound is considered as a part of any wound closure. Simple ligation of vessels is not considered as a separate procedure. Next point is simple exploration. Exploration of nerves, blood vessels or tendons exposed in an open wound is also considered a part of his essential treatment of the wound and is not separately reported. Simple ligation and simple exploration of nerves, blood vessels or tendons is not separately reported unless appreciable dissection is required. If the wound requires enlargement, extension of dissection to determine penetration, debridement, removal of foreign body, ligation or coagulation of minor subcutaneous and or muscular blood vessels of the subcutaneous tissue, muscle fascia and or muscle not requiring thoracotomy or laparotomy, use codes which come under series 20100 to 20103 as appropriate. If wound requires enlargement, extension of dissection of debridement or removal of foreign body or ligation or coagulation of minor subcutaneous or muscular blood vessels without requiring thoracotomy or laparotomy, we need to use the codes from the range 20100 20103. We will discuss in detail about this point when we talk about this particular code. So as of now, just remember the point. If wound requires enlargement, extension of dissection, debridement, removal of foreign body, etc., you need to go for the code range 20100 to 20103. Now coming to the various CPTs of repair. In the repair, we will be discussing simple repair. The first CPT is 12001. Simple repair of superficial wounds of scalp, neck, axilla, external genitalia, trunks and or extremities, including hands and feet. 2.5 centimeters or less. The repair width is 2.5 centimeters or less. The next is 12002. Here the repair length is 2.6 centimeters to 7.5 centimeters. The next is 12004. Here the repair width is 7.6 to 12.5 centimeters. Next is 12005. 12.6 to 20 centimeters. The repair length is 12.6 to 20 centimeters. Now coming to next CPT 12006. Here the repair length is 20.1 centimeters to 30 centimeters. The next is 12007. Here the repair length is over 30 centimeters. The next is 12011. Simple repair of superficial wounds of face, ears, eyelids, nose, lips, muzzle or mucous membrane 2.5 centimeters or less. The next is 12013. Here the repair of superficial wounds in the range of 2.6 centimeters to 5.0 centimeters. The next is 12014. Here the repair length is 5.1 centimeter to 7.5 centimeters. The next is 12015. Here the repair length is 7.6 centimeters to 12.5 centimeters. The next is 12016. Here the repair length is 12.6 to 20 centimeters. The next is 12017. Here the repair length is 20.1 to 30 centimeters. The next is 12018. Here the repair length is over 30 centimeters. The next code is 12020. Treatment of superficial wound dehiscence, simple closure. The next is 12012. Treatment of superficial wound dehiscence, simple closure with packing. Now coming to the CPTs of repair intermediate. The first CPT is 12031. Repair intermediate wounds of scalp, axilla, trunk and or extremities excluding hands and feet. In the previous simple case, hands and feet are included. Here 12031 excludes hands and feet 2.5 centimeters or less. The next code is 12032. The repair length is 2.6 centimeters to 7.5 centimeters. The next code is 12034. The repair length is 7.6 centimeters to 12.5 centimeters. The next is 12035. The repair length is 12.6 to 20 centimeters. The next is 12036. The repair length is 20.1 to 30 centimeters. The next is 12037. The repair length is over 30 centimeters. The next is 12041. Repair intermediate wounds of necks, hands, feet and or external genitalia 2.5 centimeters or less. The next is 12042. Here the repair length is intermediate. The length is 2.6 centimeters to 7.5 centimeters. The next is 12044. Here the repair length is 7.6 centimeters to 12.5 centimeters. The next is 12045. Here the repair length is 12.6 to 20 centimeters. The next is 12046. The repair length is in the range of 20.1 centimeters to 30 centimeters. Now coming to the CPT 12047. Here the repair length is over 30 centimeters. The next CPT is 12051. Repair intermediate wounds of face, ears, eyelids, nose, lips and or mucous membrane 2.5 centimeters or less. The next is 12052. Here the repair length is 2.6 centimeters to 5 centimeters. The next is 12053. Here the repair length is 5.1 centimeters to 7.5 centimeters. The next is 12054. Here the repair length is 7.6 centimeters to 12.5 centimeters. The next is 12055. Here the repair length is 12.6 centimeters to 20 centimeters. The next is 12056. Here the repair length is 20.1 centimeters to 30 centimeters. The next is 12057. Here the repair length is over 30 centimeters. Now let us discuss an example. A 14-year-old boy was thrown against the window of a car on impact. The resulting injury was a star-shaped pattern cut to the top of his head. In the ED, the MD on call for plastic surgery was asked to evaluate the injury and repair it. The total length of intermediate repair was 5 plus 4 plus 4 plus 5, which is nothing but 18 centimeters in total. The star-like shape allowed the surgeon to pull the wound edges together nicely in a natural Y-plasty of 2 spots. What CPT is to be reported? Here, the repair done is intermediate repair and the length is 18 centimeters in total and the area is head. So, the appropriate CPT is 12035. Repair intermediate wounds of scalp, axilla, trunk and or extremities. The repair length is 12.6 centimeters to 20 centimeters. Here the repair length is 18 centimeters. Hence we are going for the code 12035. Now coming to the CPTs of complex repair. The first CPT is 13100. Repair complex trunk 1.1 centimeters to 2.5 centimeters. The next is 13101. Repair complex trunk. The length is 2.6 centimeters to 7.5 centimeters. The next is an add-on code plus 13102 for each additional 5 centimeters or less. Repair a complex trunk for each additional 5 centimeters or less. The next is 13126. Repair complex scalp, arms and or legs 1.1 centimeters to 2.5 centimeters. The next is 13121. The repair length is 2.6 centimeters to 7.5 centimeters. The next is an add-on code plus 13122 for each additional 5 centimeters after 7.5 centimeters or less. The next is 13131. Repair complex forehead, cheeks, chin, mouth, neck, axilla, genitalia, hands or feet 1.1 centimeters to 2.5 centimeters. The next is 13132. The repair length is 2.6 centimeters to 7.5 centimeters. The next is an add-on code plus 13133 for each additional 5 centimeters after 7.5 centimeters. For each additional 5 centimeters or less, you need to report this code. The next is 13151. Repair complex eyelids, nose, ear and or lips. Length is 1.1 centimeter to 2.5 centimeters. The next is 13152. Here the repair length is 2.6 centimeters to 7.5 centimeters. The next is an add-on code plus 13153 for each additional 5 centimeters or less after 7.5 centimeters. Now the final CPT is 13160. Secondary closure of surgical wound or dehiscence, extensive or complicated. Now let us discuss an example. A patient presents to emergency department with multiple lacerations due to knife fight at the local bar. After examination, it was determined these lacerations could be closed using local anesthesia. The areas were prepped and wrapped in usual sterile fashion. The surgeon documented the following closure. So what are the closure? First one is 7.6 centimeters simple closure of right forearm. The next is 5.7 intermediate closure of the upper right arm. The next is 4.7 centimeters complex closure of right neck. The next is 10.3 centimeters intermediate closure of upper chest. What are the CPTs reported? Here, 3 different complexities of CPTs are repair are done. Complex, intermediate and simple. Total 4 lacerations are there. So first you will code the most complex repair. That is, you need to code the complex repair first. So what is the complex closure? 4.7 centimeters complex closure of right neck. Here the location is neck and the closure is 4.7 centimeters. So the appropriate code is 13132. Repair complex forehead, cheeks, chin, mouth, neck, axilla, genitalia, hands or feet 2.6 centimeters to 7.5 centimeters because here the length is 4.7 centimeters. The first CPT is done. The next is intermediate closure. Here you have 2 intermediate closures. The first one is 5.7 centimeter intermediate closure of right upper arm. And the next is 10 centimeter intermediate closure of right upper chest. So 5.7 plus 10.3. So that comes under 17 centimeters. So for intermediate repair, the appropriate CPT is 12035 along with 59 modifier. Repair intermediate wounds of scalp, axilla, trunk. Here, excluding hands and feet. Here, the code is repair intermediate wound of scalp, axilla, trunk and or extremities. Extremities are included. So here, the first intermediate closure is upper right arm. That comes under extremity. The next intermediate closure is upper chest. That comes under trunk. So those two lacerations, they come under the same code grouping. So you can add them. That is the reason why we have added 5.7 centimeters plus 10.3 centimeters will give 5 plus 10, 15, 16 centimeters in total. Sorry, not 17, 16 centimeters in total. So it comes under 12.6 centimeters to 20 centimeters range. So the appropriate code is 12053 with along with 59 modifier. The next is simple closure. What is the length of simple closure? 7.6 centimeters simple closure of right forearm. So the appropriate CPT is 12004 along with 59 modifier. Simple closure of superficial wound of scalp, neck, axilla, external genitalia, trunk and extremities. Upper forearm comes under extremities. Here including hands and feet. The length is 7.6 centimeters to 12.5 centimeters. Our length of repair is 7.6 centimeters. So the appropriate code is 12004 along with 59 modifier. By this we complete the repair topic. The next is adjacent tissue transfer or rearrangement. Now coming to adjacent tissue transfer or rearrangement. For full thickness repair of lip or eyelid, see the respective anatomical subsections. For repair of lip or eyelid, we need to see the respective anatomical subsections. And the codes for adjacent tissue transfer, they come under the code range 14,000 to 14,302, are used for excision, including lesion and or repair by adjacent tissue transfer or rearrangement, which can be a Z-plasty, Y-plasty, VY-plasty, rotational flap, random island flap, advancement flap, etc. When applied in repairing lacerations, the procedures, that is, when applied in repairing the lacerations, the adjacent tissue transfer or rearrangement procedures must be performed by surgeon in order to accomplish the repair. They do not apply to direct closure or rearrangement of traumatic wounds incidentally resulting in these configurations. So whenever we are repairing lacerations, adjacent tissue transfer or rearrangement must be performed by surgeon in order to accomplish the repair. And whenever you are repairing laceration, direct closure or rearrangement of traumatic wounds does not include adjacent tissue transfer. Direct closure or rearrangement of traumatic wounds does not include adjacent tissue transfer whenever we are repairing lacerations. Undermining alone of adjacent tissues to achieve the closure without additional incisions also does not constitute adjacent tissue transfer. Direct closure or rearrangement of traumatic wounds and also undermining alone of the adjacent tissues to achieve the closure without additional incision does not constitute adjacent tissue transfer procedure codes. Now for excision of benign lesion or malignant lesions are not separately reportable with tissue transfer. This point we have discussed in the excision session. So the excision of benign lesion, whenever they are performed together, that is adjacent tissue transfer is performed along with excision of benign lesion or malignant lesion. The excision of benign or malignant lesions are not separately reportable. And the skin graft necessary to close the secondary defect is considered an additional procedure. Skin graft necessary to close the secondary defect can be coded separately and is considered as an additional procedure along with adjacent tissue transfer or rearrangement. And for the purpose of code selection, the term defect includes both primary defect and secondary defect. For the purpose of code selection, the term defect includes both primary and secondary defects. The primary defect resulting from excision and the secondary defect resulting from flap design to perform the reconstruction are measured together to determine the code. So both primary defect and secondary defect are measured together for the purpose of code selection. Now coming to the various CPTs of adjacent tissue transfer or rearrangement. The first CPT is 14000, 14000. That is adjacent tissue transfer or rearrangement of trunk. The defect length is 10 square centimeters or less. The next is 14001. The defect length is 10.1 square centimeters to 30 square centimeters. The next code is 14020. Adjacent tissue transfer or rearrangement of scalp, arms or legs or legs. The defect length is 10 square centimeters or less. The next is 14021. Here the defect length is 10.1 square centimeters to 30 square centimeters. The next is 14041. Adjacent tissue transfer or rearrangement forehead, cheeks, chin, mouth, neck, axilla, genitalia, hands and or feet. Defect length is 10 square centimeters or less. The fifth digit 0 indicates the defect length 10 square centimeters or less. Now coming to next CPT, that is 14041. The defect length is 10.1 square centimeters to 30 square centimeters. The next is 14060. Adjacent tissue transfer or rearrangement, eyelids, nose, ears and or lips. Defect length is 10 square centimeters or less. The next is 14061. Here the defect length is 10.1 square centimeters to 30 square centimeters. The next code is 14301. Adjacent tissue transfer or rearrangement any area. The defect is 30.1 square centimeters to 60 square centimeters. The next is add-on code plus 14302. For each additional 30 square centimeters after 60 square centimeters or part thereafter. That is an add-on code plus 14302. Now let us discuss an example. A patient is 43-year-old white male with biopsy proven basosquamosal cell carcinoma of his scalp. Here the location is scalp measuring 2.1 centimeters. I marked the area for excision with gross margins of 4 mm and I drew my planned yin and flap closure. The flap rotated into defect and the total measurements of the defect are 2.9 into 3.2 centimeters. The total defect length is 9.28 centimeters. The donor sites were closed and the flaps inset into layers using 4-0 monoacryl and skin stapler. Lobe magnification was used. The patient tolerated the procedure well and the CPT code, what CPT code is to be reported here. Here the defect length is 9.28 centimeters and the area is scalp. So the appropriate code is 14020. Adjacent tissue transfer or rearrangement scalp, arms and or legs. The defect is 10 square centimeters or less. The defect length is 9.28 square centimeters or centimeters. So the appropriate code is 14020. Where the defect is 10 square centimeters or less. Here it is 9.28 square centimeters, not centimeters. Thank you for watching. Please subscribe for further videos on medical coding and CPC training.